objectives today, access determination and deviation is what we're going to be talking about. And just the students at the end of this should be able to correctly answer the following questions after completion of today's lecture. So why do I care about access deviation, and what does access deviation actually tell me? That would be the biggest question. What is cardiac access? Obviously, if we're going to be looking at things and trying to figure out how to measure and what that's actually telling us, then we should probably have a basic understanding about what cardiac access is, although many of you probably do not. And that's okay. That's why we're going to cover this today. How do we measure the access using the hexaxial reference system? And that's kind of a big word. It really is pretty simple once we start looking at that. So again, everybody in the room, regardless of certification level, you're going to be on board today and not be completely lost. So this isn't necessarily, you have to be a paramedic in order to do this or figure it out or anything like that. So if you're at the basic level, I don't think we really probably have a lot of advanced EMTs in the room, but if you are, then you're certainly going to be able to be with us and figure this information out as well. Where can I locate the computer generated access measurement? So whether or not you guys have ever paid attention to this, I don't know, but last month in the April lecture, we talked about coronary artery anatomy and kind of what that feeds, right? So for instance, the circumflex comes directly off of that left anterior descending, and it's primarily responsible for the lateral wall. So if we have a blockage in that lateral wall, or if we have a blockage in the circumflex, then that is going to show as a lateral wall infarct. So kind of having an idea of the anatomy when we look at what our EKG is actually showing us and what our findings are with keeping ST elevation MIs in mind, it's going to help point us into the right direction as to where our problem is at so that we can make sure that we're getting them to an appropriate treatment center. So if you recall from last month, we talked about things that are accurate and there are things that are inaccurate. And the thing that was accurate, if you recall, was the numbers. So if we're having difficulty determining if this is a supraventricular rhythm, maybe with an aberrant beat, or if it's ventricular tachycardia, if you recall, there was a few ways that we could do that. We could go to the top left of our printout and just look at the QRS. And remember that translates that into milliseconds. So if it's less than 0.120, then we know that it is a narrow complex tachycardia. If it is greater than that 120 milliseconds, then we know we're dealing with a wide complex or a bundle branch block. The other way that we could do that, just for review, is look in lead V1. And in lead V1, remember, it won't lie to you. So if you can just go to V1 and then simply measure wide or narrow, that too will kind of give you the information on whether or not you're dealing with a bundle branch block or you're dealing with a supraventricular rhythm. So when we're talking about cardiac access, it's much the same thing. As we look at our printout, the access information is actually printed on that is degrees. So, and I'll show you an example of that on both a printout from a physio-control device and from a Zolda device. And then how can my thumbs help determine access deviation? So, you know, in medicine, we always try to figure out something that is easier or quicker, less confusing. And somebody ended up developing, I did not develop this, so I can't take credit for that, but a thumbs method. And we'll go through that, and it makes it pretty easy for you as we're progressing through the lecture. So cardiac access, basically what we're looking at here, and I want to kind of just say this before we dive into this. If you guys can think under normal conditions, under normal physiological conditions, the heart should be under the most amount of pressure in the left ventricle. And we know that back from even basic anatomy when we were in high school, because that left ventricle has to pump blood to systemic circulation. So if I'm in that left ventricle and I need to pump blood to the fingers and the toes, I have to have a higher pressure system in order to be able to eject blood that distance. If I am in the right side of the heart, if I'm in that right ventricle, the only thing that I really have to do, my whole job in that right ventricle, is to pump blood from the right ventricle through that pulmonic valve into the pulmonary vein, and then ultimately into the pulmonary network, into the lungs. So we're not really talking today about congestive heart failure, but I want to kind of draw two parallels to you here. If I have a patient that is in congestive heart failure, there are a few things that patient should probably have. First and foremost, they should probably have wet lung sound. So when you take your stethoscope and listen, you're going to end up hearing that the patient has rales, and that should be bilateral. You know, congestive heart failure is a bilateral problem, so you should be able to hear that on both sides. The reason that they have rales in a left ventricular failure issue is because things are starting to back up. So if I back up from my left ventricle, I go up through the mitral valve into my left atria. From the atria, I go through the pulmonary artery and over into the lungs. And that is why you guys, when you're listening with a stethoscope, start hearing rales in that situation. The other thing that they should have in congestive heart failure is hypertension. So if you think about what the left ventricle has to pump against to get blood to eject, that is blood pressure. So if my blood pressure is normal or low, I don't really have to overcome a lot of pressure to eject blood from the left ventricle. I'm probably not going to be in congestive heart failure. But as that pressure continues to rise, and more importantly, diastolic hypertension, so that filling pressure is going to be very high, it makes it more difficult for the left ventricle to pump against. On the right side, however, if I have a right ventricular infarction, recall that is not necessarily going to be a problem with my lungs, because it can't even get to the pulmonary network. So things in the right side are going to start backing up, and that is when we really start to look at jugular venous distension or maybe pedal edema. So why do I bring this up when we're talking about access? Because it is a very basic understanding of the electrical physiology in the heart as to why we're even talking about this. Under normal conditions, if the left ventricle is the one that is under the most amount of pressure, the left ventricle should also be the area that is getting the biggest boost of an electrical impulse. So under normal conditions, normal physiology, we should see a left axis. And that's just talking about how the electrical impulse is basically going down. And if it's going down into that left side, then we know that things are probably normal. But if for some reason you're looking at axis and you determine that the patient has a right axis deviation, that tells you that the electricity is not going to the left side, it is going to the right side. And the reason that it does that is because now that right side is working it's working harder because it is having difficulty. So if we see a right axis deviation, that should be a pretty automatic clue that, hey, the right side is working harder than the left, and that is not a normal finding. So we'll talk about why some of those things happen. And again, if you guys have questions, because in 20 plus years teaching paramedic education, I don't know that we have ever truly covered axis deviation in initial education. So unless you guys have additional training, additional backgrounds, you probably have not had this information, but it is easy to do, and it will give us a lot of information. So let's kind of take a look at it. All right, so the average direction of the depolarization wave. So again, I'm just going to kind of hit high points here. Normal condition, we depolarize from that SA node, and we know that that electrical impulse goes across the atria on both sides. It comes down to the AV junction. That holds the message to allow the ventricles time to fill. And then the AV junction allows the electrical impulse to go down, and it goes down towards the ventricles. And remember that the heart is kind of seated in the chest, and it's tilted just a little bit. So under normal conditions, the heart is depolarizing from the right upper to the left lower, much like the arrow was kind of showing you. And this will become important as we talk about the normal flow for access. So if you kind of think about this in the terms of quadrants, or the atria versus the ventricle, in that right upper quadrant, where the arrow is starting, that is the right atria. And then where the arrow is ending is the left ventricle. And that makes sense based on what we just talked about. That left ventricle is under the most amount of pressure. So it's going to end up receiving the biggest amount of electricity, or it should be under normal conditions. All right, so if you recall back to last month, we talked about Einsteins Triangle, and I'm not going to get real deep into this, but there are a couple things here that I do think are important to kind of point out. So if you're looking at the triangle up in the top, remember that the right arm is a negative lead. So if I am looking at lead 1, and that's just the Roman numeral at the top of the triangle there, lead 1, then the electrical impulse is going from the right arm over to the left arm, which is a positive lead. So you have a negative going towards a positive, and that should always give you an upright deflection on your EKG tracing. If I'm looking at lead 2, I'm going from that negative right arm lead down to my positive left leg lead. So again, I'm going to end up having a positive deflection on my EKG finding. And then if we're looking at lead 3, the left arm is a negative lead. It's going down towards that positive left leg lead. So lead 3 should too be a positive finding. So Einsteins Triangle basically is kind of showing you that the leads and the way that the electricity is flowing, if it's going from a negative to a positive, then it should always give us an upright deflection on our EKG. So let's look at the 3 examples of the EKG tracing. And again, there's not a ton of information here like that you guys have to study and write all this stuff down, but I do want to just kind of point out a few kind of high points here so that when we're looking at axis deviation, it'll make it a little bit more clear for you. One thing too that I forgot to mention, Brandon, when he sent this information out, to your EMS coordinators or whoever is responsible for getting the class pulled up today, there is a chart on this. So if you guys want to print off, it's just a 1-page handout basically that kind of shows you the different axes, and it may be helpful or beneficial to you if you're one of those people that likes to have something in front of you and you can kind of draw on. Brandon has taught this many times in a classroom setting and never had the handout necessarily. And people grasp it pretty quickly. So, but if we're looking at the EKG tracings, and we'll start on the far left there, that positive. So if you have a positive waveform, meaning your R is greater than the S, then that tells you that the electrical impulse was flowing from a negative towards a positive. So in the equiphasic, and this will become probably the most important thing that we talk about, equiphasic is basically talking about it being equal. So my R wave is equal to my S wave. And if you guys just kind of look at that waveform, it's basically, for all intents and purposes, and I'm again not going to necessarily break down R's and S's, but if you just look at the amount of electrical impulse that is going up, it basically is equal to the amount of the electrical impulse that is going down. So my R wave going up is the same as my S wave going down. And that's what equiphasic is. And please remember the equiphasic, because as we start looking at these, you're going to have to pick out which one is the most equiphasic. And all we're looking at, again, is which one looks that it's pretty close to being even above and below the isoelectric line as far as your R and S wave. And then on the third one, or the far right, it's the negative finding. So basically here, our R wave is less than the S wave. So if we remember, an R wave by definition is that first positive deflection, okay? And it's either basically after a Q wave or after a P wave, depending on if you have a Q wave or not. But the R wave should be a positive deflection. So if I'm looking at that, I can see I just have a very small R wave, but then I have a huge S wave, and then it comes back up to the isoelectric line to make or form my T wave. So hopefully everybody is okay with looking and understanding positive and negative. And then what's new on this particular slide for most of you is going to be the equiphasic. And again, all I'm looking at is that the R wave equates to the S wave. And there's no measurements or anything. It's just a visual look. All right. So then when we look at axis deviation, we're looking at a bunch of different things. And this is kind of a busy slide, if you will, but we'll start kind of populating some things in here. But I do want to point out one thing. If we were just to take this and quadrant it off, and I was just going to do 4 pieces of the pie here, then my horizontal line would be lead 1. And my vertical line would be AVF. So if I were to take just 2 lines and draw one line from AVF to AVF, and then the other one from lead 1 over to lead 1, that would be how this is typically cordoned off, or how they break down the quadrants when you're looking at this. So there's lead 1. Now, if I went back to Einstein's Triangle, I want you guys to think about where lead 1 is at. And if you can do that, and if you can recall that it's coming from the right arm over to the left arm, then this should make sense to you. Lead 1 is basically going from the right arm to the left arm, so it's going straight across, and that is why the horizontal line here on axis deviation is lead 1. And then AVF should always be basically a negative if we're looking, I'm sorry, not a negative in AVF, it's AVR that's a negative. AVF, if you think about how your EKG printout is, it's lead 1, lead 2, and lead 3, and then AVR, AVL, and AVF. So AVF is going to be the third one, or the bottom one, basically, on the augmented voltage leads. So in lead 1, there are a few things that you have to kind of recall. Lead 1, and it's a positive, is going to end up being 0 degrees. Okay, and all I'm basically doing here is kind of quadranting off the different areas that we're going to be talking about. And again, if you're lost at this point, just kind of hang tight and bear with me for a few minutes, and I think it will all start to make sense. So if you're looking at the left side of your screen, that is the division between 180 positive and 180 negative. If I'm at the bottom where AVF is at, that is a positive 90. If I'm at the top, that is a negative 90. And then we look at lead 3. So lead 3, AVR, and AVL are the different pieces of the puzzle. So if I'm just looking at 4 different pieces here, the 4 original lines that I put in, remember that lead 1 is going to go from 0 to a positive 180 degrees. The halfway point of that is positive 90. And actually, incidentally, if you kind of look here, lead 1, where the 0 is at, and I'm kind of bringing my cursor across there, down to 90 encompasses which one of the chambers of the heart. And if you guys are thinking that, well, from 0 down to 90, we are basically looking at the entire left ventricle, then I would tell you that you're on the right path. So under normal conditions, and there is a caveat here, and I'll kind of pick this up, under normal conditions, our axis in normal patients should be between 0 and 90 degrees positive. And if that is what you're finding is, then that tells me that the left ventricle is getting the most amount of energy. And I'm going to give a second here for any type of questions. If you guys have questions, please put it in the chat or unmute yourself, because I just want to make sure that I'm not losing anybody at this point. Okay, seeing none, I'll continue to move. So again, just to kind of review here, that left ventricle is housed in between 0 and positive 90. So if things are functioning correctly, then the electrical impulse should be coming up from that right atrium, basically the SA node, and the bulk of the electrical impulse, or the axis, should be going towards that left ventricle, and it should be between 0 and a positive 90 finding. All right, so I kind of added a couple other things in here, and it makes it a little bit busier. One thing, and actually there's a slide coming up that kind of talks about that, and I mentioned that there was a little bit of a caveat. So the caveat is normal really goes up to this black line, which is showing AVL, and that's an up arrow, and a negative 30. So anything from negative 30 up to a positive 90 is going to be considered normal, okay? And then anything outside of that is going to have other breakdowns. It could end up being that it is a right axis deviation. It could be that it is a extreme right axis deviation, and all of these things have different findings that go along with that. So let's look at this quadrant picture here, and hopefully this kind of clears up what we're talking about. From lead 1, remember 0 to 180 degrees, and that caveat goes up to that negative 30. So negative 30 down to that positive 90 is what is considered physiologic left axis. And remember, anytime we're talking about anything physiological, that is a normal finding. That is anatomy and physiology, how things are supposed to work. If I go from that positive 90 to the positive 180, so just for reference, I'm in the bottom left portion of the screen, that is going to give me a right axis. And if you look at where that quadrant falls, it's falling down basically to that right ventricle. And this will become important as we talk about why you get some of these things that you do. So positive 90 up to positive 180 is going to be considered a right axis. As I continue to move up the clock there, essentially, I'm in the top left of the screen. This is going to end up being a negative 180 all the way up to that negative 90. And this is considered an extreme right axis deviation, extreme right axis. So negative 180 to negative 90. And then as I continue to just kind of move around there in the top right, negative 90 all the way back to a negative 30 is going to be considered a pathological left axis. So pathological problem. We have an issue. We don't know why, but we can try to maybe figure some of this stuff out. So let me just kind of clear this up real quick. The only one on the screen here that is normal is the negative 30 up to the positive 90. And if you have a patient that has a printout in that range, then you know that the left ventricle is getting the bulk of the electrical stimulus. And that tells you that things are functioning normally. It doesn't tell you that they're not having a STEMI. It doesn't tell you that they may not be having other conditions, but it tells you as far as the electrical impulse, things are going the way that they're supposed to. If you have a right axis, an extreme right axis, or a pathological left, that tells me that there is something abnormal going on, and then we can kind of think through what those things may be. All right, so why do I care? Why does this even matter to me? And, you know, I'm going to kind of take just a second here to mention this. Remember that when we start talking about this, and for those of you that we talked to from an administrative standpoint, we didn't want this to be just a typical Brady and nothing wrong with Brady or Nancy Caroline or whomever. We don't want it to just be the same thing that people have heard over and over and over. So, you know, if you're sitting here like, why is this guy talking about axis deviation? Well, because technically by definition, this is continuing education. And we want to try to bring in other things that maybe you may be familiar with and maybe you're not. And if you are familiar, then hopefully it's just a little bit of a refresher to you. So why do I care about axis deviation? Well, let's take a look at this. So, and I'm going to give time for everybody individually in your firehouses there to kind of look and tell me what you think about this EKG. And actually, if somebody will unmute or put something in the chat, I would appreciate that. So just as a group, you guys look at it and tell me what you think, or what do you see on this? I just gave Belby Dayton and Cody the ability to talk. Everybody else has ability. All right, so let me make make sure you chat. All right, so if we look at this, a couple different things we can look at. We should be looking at the EKG as a whole, and probably what most of you guys are doing and what your eye is trained to do is immediately start looking for elevation, right? So if we do that, I look at lead 1, AVL, V5, and V6. I don't really see any elevation there. I go to 2, 3, and AVF. I don't really see any elevation there. When I get to my V leads, though, I see a flip T wave and ST segment depression in V1 and V2. I also have a flip T and ST segment depression in V3 and V4. And then I have ST segment depression, but not necessarily a flip T wave in V5. So if I were to give you guys this 12 lead EKG, or you make a run today and you pick this patient up, when you're looking at this EKG, what would you call in with? You probably would call in with, hey, you know, I'm bringing you a patient that I have some basic ST segment depression telling me that I've got some hypoxia or the patient's not getting enough oxygenated blood flow in leads V1 through V5, okay? So this should kind of raise your index of suspicion that, hey, I need to do something for this individual potentially, because depression, we know if we don't resolve that, is going to end up flipping up and becoming a STEMI. So this patient here would probably be a candidate for your monotype therapy. But as far as elevation and anything else going on with your patient, you may not necessarily be able to pick up on at this point. But I can tell you that what we're going to do is at the very end of this, we're going to come back to this exact 12 lead. And I think that you guys will see some things differently than what you're seeing right now. All right, so pathologic left axis. So remember that a left axis is normal, but a pathologic is abnormal. And remember that the pathologic is that negative, the negative 90 up to a negative 30. So that is outside of that negative 30 to a positive 90. And that's why this is becoming a pathological left axis deviation. So things that cause that: left ventricular hypertrophy, left bundle branch block, right bundle branch block. So remember that in your right bundle branch block, if you have a left axis deviation, you probably have a blockage of the left anterior fascicle. And it kind of shows you in that right upper picture where that left anterior fascicle is actually coming down. So as I come down the bundle of His, and then it bifurcates into my right bundle and my left bundle, that first little fascicle that comes off is called the left anterior fascicle. And if I put a blockage there, then it's going to give me a right bundle branch block with the, a bundle branch block with the left anterior fascicle. And that is actually a left bundle branch block. The right bundle branch block with right axis deviation is on the left posterior fascicle. So it just kind of further dives down as to where the blockage may or may not be. And I don't know that this is something that like we would necessarily call in with. Basically, it would just be, hey, I'm bringing you a patient that has a right or a left bundle branch block. The reason that this is important is because we've all taken care of these patients. Everybody in the room that is experienced and has been doing this for a little while has taken care of somebody that has a bundle branch block. And probably most of you have taken care of a patient that also has where you've seen left ventricular hypertrophy. So other things that will give you a left axis deviation: inferior wall MI, Wolff-Parkinson-White syndrome, and then ventricular tachycardia. And just keep in mind that ventricular tachycardia can basically give you any of the different axis deviations that we're going to be talking about. So right axis deviation. So think about this. Signal is coming down and it's making a hard right, okay? Because that right ventricle is now requiring the most amount of electrical stimulus because it is working harder than it should, and it should not be that way. So right axis deviation, we have RVH, we have right ventricular strain, we have lateral wall MIs, so that lateral wall is infarcting, hyperkalemia, and we get something there called a sine wave if it's severe. And a sine wave it's basically a waveform that is found like in trigonometry. So it's a mathematical thing essentially, But what ends up happening is you end up getting what's called a sine wave in the presence of a patient that has severe hyperkalemia. So this is not a normal potassium is 3.5 to 5. This is not somebody that's got a potassium level of 5.1 or 5.5. We're talking potassium levels that are 7, 8, etc. So it would be way outside that normal finding. And oftentimes what you will find is if you can pick up on it, the patient will have what is known as a sine wave prior to going into VFib or asystole. So if you're doing a 12-lead EKG, you see that the patient has right axis deviation, and then all of a sudden they have a sine wave, that patient is getting ready to cardiac arrest on you. So with Parkinson-White, we've already mentioned once before a condition called Dextrocardia. And we'll kind of talk a little bit more about Dextrocardia and what this is. And it is something that you are able to see. Brandon and I actually were on a medic unit together and picked up a patient that had Dextrocardia. And it kind of threw us for a loop at that time. So I'll kind of talk about that here in a few minutes. It could be a normal deviation in the pediatric patient, and then again, in ventricular tachycardia. So why might this be a normal finding in a pediatric patient? So if you guys recall me saying that everything should be left because that's the most pressure that we're under, well, if now all of a sudden in pediatrics, I'm saying it could be a normal finding up to about the age of 3, why do you guys think that is? And I'll give you a second to discuss this. So the reason that you may have a normal variation of a right axis deviation in the pediatric age group, particularly in young, is because they don't have normal circulation through the heart. So when they are in utero, they're not getting blood flow through the same pathway that you and I are. So remember that when they take their first breath, valves start to close, other valves start to open, and then blood starts to actually go through the normal way. So because of that, they may have a normal right axis deviation, but that should go away as the child gets older and older. And then if we look at extreme right axis deviation, we have ventricular rhythms, ventricular accelerated, idioventricular rhythms, PVCs, hyperkalemia again, and then that's severe RVH. So right ventricular strain, I want to come back to this, and then I'm going to challenge you guys on something. So right ventricular strain could be COPD or emphysema. It could be a pulmonary embolus, or it could be pulmonary hypertension. So what I want to kind of ask the room, and again, not necessarily looking for you guys to talk unless you need to or want to, but I want you guys to think about patients that maybe you have dealt with that have had some of these things. And I think that if you guys are being honest with yourselves, you've probably seen most of them, depending on how much experience you have. So if we're talking about COPD and emphysema, this is like 80% of the calls that we go on. What about pulmonary embolus? I'll bet you most of the paramedics have taken care of a patient that maybe we didn't know was a pulmonary embolus, but by the time we get them to the hospital, that is in fact what it was. Pulmonary hypertension. So pulmonary hypertension, if we just think about what pulmonary hypertension is things kind of backing up. So think about a patient with pulmonary edema. If I have a bunch of fluid in my lungs, then it's going to end up creating a higher pressure in that pulmonary network. And that's basically the easiest parallel to draw with pulmonary hypertension. What about MIs? Yeah, we've seen lateral, we've seen septal anterior, extensive anterior MIs. We've seen all of them probably. You probably have seen patients with hyperkalemia. Maybe you didn't see them with a severe hyperkalemia or a sine wave, but maybe you just looked at the patient and they had that tall tinted T wave telling me they might actually have hyperkalemia. You may or may not have taken care of patients with Parkinson-White. Not super common, but I've had probably 5 in my career that have told me they've had WPW. Dextrocardia, I am only aware of 1 patient that I have taken care of that has had Dextrocardia. And then VTAC, we've all taken care of patients that have had ventricular tachycardia. So this is why this is important, you guys. If we can look at an axis and help us kind of determine what is going on with our patient, it's only going to allow us to open up the door and the pathway for proper treatment. And we know that we're going to be able to do that based on protocol and findings that we have in the pre-hospital setting. All right, so Dextrocardia, this is worth mentioning here because this is going to kind of change the game a little bit. What Dextrocardia is basically things are kind of flipped. So if you look at this patient, the heart typically sits in that left upper quadrant, kind of in front of the left lung, as you guys know. In a Dextrocardia patient, the heart is actually on the right side. And there's actually even something, so Dextrocardia just means that the heart is flipped. And then there's a whole nother condition, Dextrocardia totalis inversus, which basically means that everything is flipped. So if you kind of look down here into the abdominal cavity, the liver is now in the left upper quadrant, and the gallbladder, the liver and gallbladder in that left upper quadrant, and then the pancreas and the spleen are in the right quadrants, and it should not be that way. It should be flipped the other direction. So I want to ask you a question. If you have a patient that has Dextrocardia, and we're not going to go into totalis inversus, which is all of the organs, we'll just talk simple Dextrocardia, and you did a 12-lead EKG or you did a simple EKG, what do you think that your EKG findings would be? Anybody have any idea or want to take a stab at it? You put all your leads on, you hit print. What do you think that your findings would look like? Okay, so if we know and remember Einstein's Triangle, just simply, I'm going from a negative over to a positive. It should give me a positive deflection on my EKG. Well, if now things are reversed, I'm actually going towards a negative lead, okay? So in the situation where Brandon and I had a patient like this, it was a backup run for the city of Covington. We picked this gentleman up, and he told us, he goes, I don't know that he had told us that he had Dextrocardia, and in full transparency, I don't know that I would have known what it was at the time. But essentially, when we went to do the EKG, he said that we were doing it wrong. So it was like, okay, we've done this a bunch of times. We're going to go ahead and just do what we know we need to do. So we do the EKG, and basically when we get the printout, it tells us that the leads are reversed. So when we start looking at it, it's like, well, okay, things are backwards here. So when we look, the leads are not in fact reversed. It's just the printout telling us that things are reversed. So at that point, the guy basically tells us that his inside, his heart, is on the wrong side. So you can hopefully appreciate that if it looks the way that it does under normal conditions, if I were to switch that 180 degrees on the inside, it's going to give me an opposite finding as I do my 12-lead EKG. So a Dextrocardia 12-lead EKG will look something like this. So if I look in lead 1, remember lead 1, lead 2, and lead 3 under normal conditions should be a positive finding. But what I have here in Dextrocardia is I have a negative in lead 1, I have a negative in lead 2, I do have a positive in lead 3. The other thing that I want to point out here is this. Remember that AVR should always be heading in a negative deflection. And if it's not, it tells us that something is wrong. So when I look at AVR in this particular 12 lead, I can see that it's a positive deflection. And that should be a clue to me to either check my leads and make sure that I have them on correctly. And if I do, which we did that night, then you need to start asking your patient other questions. And that guy was aware that he had Dextrocardia and basically just told us that we had to do things differently. So not really listening to the patient, and kind of learned a lesson that night, you know, and the outcome was fine. We took the guy to the hospital, he was fine. But Dr. Spellman was the ED physician that day, and we talked to Dr. Spellman about that and basically asked him like, okay, in the future, how would we do this? And he said, you would do it the same as you normally would, just in the reverse. So you would have to flip your limb leads, you would have to flip all of your V leads. So essentially you would end up doing, you know, your 12-lead EKG on the patient's right side versus the patient's left side. And if you do that, then it should tell you, it kind of tricks the machine into thinking that things are normal, and it should give you a printout that you're now able to interpret. So it doesn't happen a ton, but there are patients out there. And as I said, we do have at least one here locally because we've taken care of him before. All right, so determining axis. There's basically 3 ways to determine it. You can either look at the computer measurement. We can do a manual calculation using the hexaxial reference system, or you can simply use your thumbs. So computer measurement. So here's a printout of a Zoll. And if we look at axis, the one that we're really looking at or concerned with is the QRS. So if you come down here on the paper, it's probably the eighth or ninth thing down. The QRS axis is telling you that it is 54 degrees. So if you guys are able to see that QRS 54 and then the degree symbol, that tells me that this patient has a QRS axis of 54. And remember that if it falls between -30 all the way up to a +90, that is normal. So as I see that 54 tells me that this is a normal axis. This patient has a left axis, which is a completely normal finding. If I'm looking at a physio device, a LifePak 12, LifePak 15, hopefully 15s at this point, you can see different things. So look up in the kind of the center of the screen where it has P-QRS-T. So, and then if you look over at the numbers, those are your respective numbers. So that the P would have an axis of 22, the QRS is -19, and then the T is 77. And remember, we're only really focusing on the QRS. So this is a -19. What is our normal? The normal is -30 up to a +90. -19 falls within inside of that. So this is a normal axis. This is nothing abnormal here, but that's how you would do it, basically looking at the machine. All right, so manual calculation. There's 2 different ways that we can, or 2 more ways that we can do this. We can either do a manual calculation, or you can simply use your thumbs to figure out if the patient has an axis deviation or not. So when we're looking at this, this is an important part. You are only going to be looking at leads 1, 2, and 3, AVR, AVL, and AVF. So when we're looking at axis deviation, do not look at anything in any of your V leads, your V1 all the way through your V6, we are eliminating as far as axis is concerned. So only in the first six leads on the left side of your printout are we going to be looking at. All right. So first thing we need to do is we need to identify the lead that is the most equiphasic. So equal, if I look in leads 1, 2, 3, AVR, AVL, and AVF, which one of those is the most closely going above the isoelectric line and below the isoelectric line? So the R wave going above and the S wave going down. And I'll just kind of give you this as an example. If I look in lead 1, for example, my R wave is pretty tall, right? And if I were to measure it, it's probably 5, 7, it's probably 8, okay? If I'm measuring in millimeters going up. And if I look at the S wave might be like 2, okay? 2 or 3. So 8 and 2, not really equal. So lead 1 would not be the one that we are looking at. And if you guys are kind of thinking along that path, then you're on the right track. So as I look at this, I think that the one that is probably the most evenly dispersed above and below would be AVL. So if I look at AVL, I have about half going up and I have about half coming down. So I would choose AVL as the most equiphasic lead on this particular EKG. And hopefully you guys did the same thing. All right, so here's just a little bit, a different kind of view of this. If you're looking here, I have AVR, AVL, and AVF. If I look at AVF, it is the most equiphasic because I have about an equal amount going up as I do going down. You can see clearly AVL is not your answer, and then 1, 2, and 3 are not going to be your answer as well. So AVL, again, This is just another picture of the EKG that we were just looking at, that AVL, half going up and half going down. And you cannot see AVR is just kind of blended in up there as far as the printout. All right, so full transparency, I didn't make this up. This was a gentleman that has come up with this from somewhere on the East Coast, somewhere, I think Virginia maybe. This is not made up by me, but he basically uses a star of life as our reference point. So if we take the star of life and then we simply turn it on its side, this is going to allow you to determine whether or not, or which lead you should be looking at to determine what the axis deviation is. So kind of here, if I'm just looking at this, I want to point something out here real quickly. If I am in AVL, okay, which is the one that is the most equiphasic and AVL points straight across to lead 2, okay? So if my equiphasic lead happens to be AVL, then I would come over here to lead 2 because this is a straight line. If my equiphasic hypothetically was in lead 2, then it would show me that I need to look in AVL because it is a straight line. If I come up here to lead 1, and lead 1 was my most equiphasic, then look where that line is pointing. It's pointing down here to AVF. AVF points to lead 1. And then if I'm in AVL, it's pointing to 3, and 3 is pointing to AVL. And we have some arrows here that will kind of help show that. So this is really kind of the whole premise of what we're getting ready to look at. Hopefully you guys kind of understood the quadrants and where the numbers are going to fall. And then if you can understand this, you're golden. So just remember that AVL and lead 2 would be on the same plane. AVL and lead 2 are on the same plane. AVR and lead 3 are on the same plane. And then 1 and AVF are on the same plane. Just kind of follow the arrows to the direction that you're wanting to go. And it kind of gives you essentially the same pattern, if you will. So 55 degrees here. I want to ask you guys, where do you think that the 55 falls in? So if I'm at 55 degrees, am I going to have a left axis? Is it a right, an extreme right, or is it a pathological left? 55 degrees is going to fall within that -30 to a +90. So I know that this is going to be a normal EKG as far as axis deviation is concerned. Not a whole lot to worry about here. So what if we have a split axis? What if we're unable to determine which one is the most equiphasic? Well, let's look at that. So if I look in lead 1 and I look in lead AVL, I could probably make an argument that those are pretty close. I have lead 1 is about half up and about half down, and lead AVL about half up and about half down. Man, I really cannot decide. So what we would end up doing is we would end up taking that hexaxial reference and we would have to apply that to the chart that hopefully you guys kind of have in front of you. So if I take AVL and I come back on that hexaxial reference using that star of life, it's going to end up taking me to lead 2. Okay. And I'm going to kind of jump ahead here for just 1 second. So if I'm looking at, let me back up for 1 second. I'm looking at AVL. Okay. And AVL is pointing back to lead 2. So if I'm at AVL and I'm looking back at lead 2, what is my axis at this particular point? Anybody want to take a stab at it? Sorry, I thought somebody was in the chat. All right, we'll come back to this. Look at 1 and AVF. So I'm telling you that I think that 1 is the most equiphasic in addition to AVL. So if I look at this, when I look at 1 and AVF, I should be able to plot this on the chart. So one concept that I think is very, very important to you guys have to do this or you're not going to be on the right path. When I look at AVL, okay, and I know that AVL points back to lead 2 because of the star of life. When I look at lead 2, I need to figure out, is lead 2 going positive or is lead 2 going negative? And that is the first question that you have to ask. And this in lead 2 is a clear positive deflection. So when I go to the chart, what I need to do is find lead 2, and this blue arrow pointing up is telling me that that is a positive finding. So lead 2 positive is a positive 60 degrees. That would fall within the normal limits. Well, if I go back to this chart once again, and I now look at lead 1 is also equiphasic. You know, they're pretty close, 1 and AVL. So then I come down to AVF. And remember that if I look at AVF, I need to determine if that is positive or if this is negative. And if it is a positive, then I need to find a positive AVF on my chart. So when I find my positive AVF, here's my arrow going up telling me it's positive. It's AVF. That is a positive 90. So if you have a split axis or if you have a situation where you're not really or able to determine the equiphasic waveform, you basically split the difference. So what we would do is we would take this positive 60 and this positive 90 and we would split the difference. And if I did that, it would end up being a positive 75. So this particular EKG, when I look at the QRS axis, it is giving me 76 degrees. And that tells me that that is a normal finding. Okay, it's in that left quadrant, it's a left axis. Things are probably okay as far as axis is concerned. Now, if you look up at the top right, it says sinus rhythm, inferior infarct, age undetermined. So I'm not telling you that you couldn't have other things, but as far as the electrical flow, things are operating the way that they should be operating. Any questions about that? All right, let's look at a few more of the hexaxial reference, and then we'll take a break before we do the thumbs method. So, sorry, thumbs method came up quicker than I had anticipated that it was going to. So the thumbs method, let me go ahead and take a break here. We've been at it for about an hour. We'll take a break. We'll come back and we'll do the thumbs method, and then we'll jump into the next portion. If you guys have questions, again, feel free to unmute yourself or put it in the chat. I will pause the video at this point. So question real quick, can lead placement affect axis? And the answer to that is absolutely, especially if your leads are on inappropriately or they are, you know, if you have your right and left limb lead reversed, for instance, then yes, it could definitely affect axis. The flow of the electrical impulse towards the heart should obviously not be affected. So if the left ventricle is requiring the most amount of energy, we'll call it, then, you know, the energy is going to go to the left. If the right ventricle is your problem, then you're going to have a right axis deviation. So that's not going to change. But yes, if your leads are not on appropriately, it can certainly throw off what your axis looks like. And a case like that would be kind of like the Dextrocardia. We had our leads on correctly in that particular instance. The guy's insides were reversed. Same concept would hold true. If his insides are normal, but we have our leads reversed, it would show us an opposite finding. Does that answer your question? All right. So let me go ahead and just kind of pause the recording. We'll take about a 10-minute break. We'll be back about 10:08, and then we'll wrap this portion up. We're almost done with this, and then we'll jump into the second part. All right, any other questions about what we've talked about up until this point? What we'll do is we'll go through the thumbs method, and then after the thumbs method, then we'll have 3 or 4 of these that we can look at and kind of put them into practice so that you guys can kind of use the hexaxial system, or you can use the thumb system, kind of figure out which quadrant you think that these patients are going to be in. So any questions at all? All right, The other thing here is just kind of a rule, if you will, in air quotes. I'm going to make sure that my camera is on and you guys can see me. So as I'm doing this, if you guys will kind of watch how I do my thumbs, and basically just kind of put a rule to it. Like if we're talking about lead 1, we're always using the left. And if we're talking about lead 2, we're using the right. And I'm not sure exactly how that's going to translate on the image. Hopefully it'll be right on and not backwards to you guys, but this will make sense as we're kind of progressing through here. So the thumbs method. So if we're going to use the thumbs method to determine what axis is, then we're going to use lead 1 and lead 2. Those are the 2 leads that we're going to be looking at. So it's a little bit easier to do. It's not going to give us probably as precise of information as what the hexaxial potentially would. And it's definitely not going to give us as precise as what the printout would do based on like your physio control here, telling us that this is a 55-degree axis. However, it is going to put us in the right quadrant. So you're going to know whether it's a normal axis or if it's an extreme right axis deviation. You'll be able to pick that up just by using your 2 thumbs. So I kind of mentioned to you that we're going to use lead 1, and I'm going to use my left hand for that. And I'm going to use lead 2 is going to be my right hand. So I've got 2 thumbs, right? So if I'm looking at lead 1 and it is upright, meaning that your deflection is going up, I'm going to give that a thumbs up. If I'm using lead 2 and it is a positive deflection, then I'm going to give that a thumbs up. And that's all that we're going to be kind of doing here. So normal axis here, I look at lead 1, it's positively deflected. And then I look at lead 2, it is positively deflected. I have 2 thumbs up. That tells me that everything is right and things are working the way that they should be. I'm giving this 2 thumbs up. It is a normal axis deviation. And Chief, the question that you had about if your leads were on incorrectly, would it change the axis? And this is a good example of that. If I have my limb leads reversed, for instance, remember from last month, if you guys were on or if you recall, if our limb leads are reversed, we're going to have something called global negativity in lead 1. So that means my P wave, my QRS complex, and my T wave are all going to be flipped. So if I'm using the thumbs method, for instance, that would give me a thumbs down because that would be negatively deflected. And then lead 2 would either be positive or negative. So you could see that it could kind of throw things off, and it would definitely throw off your numbers in your printout. So yeah, make sure that your leads are on correctly. All right, so positive in lead 1, positive in lead 2, 2 thumbs up, normal axis deviation. Pretty simple. All right, let's look at a left axis deviation. So if I look at lead 1, remember we're only looking at lead 1 and lead 2. I look at lead 1 and it is positively deflected. I give that a thumbs up. I look at lead 2 and it is a negatively deflected. Okay, we have the S wave is going below the isoelectric line. So in lead 2, I would give that a negative deflection. So if I have 1 thumb going up and I have 1 thumb going down, my thumbs are leaving each other as far as the direction. They are leaving L, and that would give me a left axis. So it depends on how severe this is. It's probably going to end up being a normal finding, but an up in lead 1 and a down in lead 2, my thumbs are leaving. That gives me a left axis. A right axis deviation. So I look at my lead 1 and my lead 2, and on my lead 1, I am going down, and on lead 2, I am going up. These 2 are heading right towards each other, okay? The thumbs are heading right towards each other. This is a right axis deviation. So down in 1 and up in 2, using your thumbs are heading right towards each other, right axis deviation. So kind of ask the question here, and again, not necessarily looking for a response, but if I simply did that, I have my leads on correctly, I do an EKG, and I use 1 and 2, and I do this and this, and I say they're heading right towards each other, giving me a right axis deviation. what are some conditions that this patient may be suffering from? And the answer to that is, if my right ventricle is requiring all of the workload, basically, meaning it gets the most amount of an electrical stimulus, I'm probably dealing with something that has affected the lungs. If the lungs are the problem, now my right ventricle has to work harder. So this could be a pulmonary embolus. It could end up being that the patient has pulmonary edema. It could be right ventricular infarction. So there's all kinds of different things that I could start to think about as to why my right ventricle is under a higher pressure, okay, to function correctly. And then the final one is we are going to look at extreme right axis deviation. So again, same concept. I'm looking only in lead 1 and lead 2. I have down in lead 1 and I have down in lead 2. And if both of those are down, that is bad. Okay. And we end up calling this dead, dead. So, and if you look, I'm going to kind of back up here just for a second to clear the image up. If you look in lead 2, what would you guys call that? That is a monomorphic ventricular tachycardia. So mono meaning one, so they look the same, okay? Polymorphic, poly means many. For those of you that don't typically read EKGs, polymorphic VTAC means that it has many variations. Monomorphic VTAC means that it looks the same, and this looks the same. The other thing that students a lot of times will kind of tell us, like, oh, I kind of see the marching nuns. So if you can kind of just see that there's nuns there and they're lined up and they're kind of marching, and that tells me that this patient is in VTAC. Well, VTAC, ventricular tachycardia with extreme right axis deviation, that is not a good sign, okay? And I think we can all agree on that as pre-hospital providers. When we have somebody in ventricular tachycardia, true VTAC, you know, it kind of makes us feel like we need to be at the hospital fairly quick before this patient goes into an arrest situation. So just simply looking at lead 1 and lead 2 and doing down and down, 2 thumbs down, not good. We call that dead, dead. All right. So that's the thumbs method. Not very difficult to do that. So a little caveat here, if lead 2 is the equiphasically doing the thumbs, then you would end up using lead 3 or lead AVF. And again, it's just kind of a one-off thing worth mentioning. All right, so let's practice here for a few minutes. So if I look, remember, I'm only looking at 1, 2, and 3, AVR, AVL, and AVF, so my V leads are eliminated. So a couple different ways you could do this. You could either look at your printout, you can do the hexaxial reference, or you can do your thumbs. So just kind of looking at this, and I'll give everybody a second to do this. What are you guys thinking that this probably is? So if we're doing the thumbs, then we would do up in 1, up in 2, it is up. Both sides are up. I've got 2 thumbs up. This is a left axis. So things are probably normal here, correct? If I'm using the hexaxial system, remember that I have to find the equiphasic lead. So when I look here, the one that is the most equal to me looks to be AVL. And if I end up putting my star of life there, remember AVL points to lead 2. So what I have to do is determine, is lead 2 upright or down? And in this particular situation, it is upright. So I know that this is going to end up being a positive 60. And how did I get that? Because positive 60 is where it would fall into the chart. I have an upright, look at the blue arrow, in lead 2, that is a positive 60. So this is a left axis, which is a completely normal finding. So your thumbs method worked. All right, let's look at this one. 1, 2, and 3, AVR, AVL, and AVF. If I look at lead 1, I have lead 1, if I'm using thumbs, that's going down. Lead 2 is equiphasic. So I look at this and say equiphasic, so then I have to look at lead 3 or AVF. Remember that caveat? So I have leads 1 going down, and I have 3 or AVF really going up towards that. They are heading right towards each other. This is going to be a right axis deviation. So let's use the hexaxial system. I take my star of life. I put it on there. Sorry, the star life's not on there. As I look at this, if lead 2 is my equiphasic lead, remember that I should go over to AVL at that point, because that's how the star life would line up. When I look at AVL, that is negative. So now I have to find on my chart a negative AVL, and the answer would end up being that positive 150 degrees. So I look on my chart here, my blue negative next to AVL gives me a 150 degree. So just by simply looking at this, I can tell that this is a right axis deviation. And that may be the issue as to why my patient is in congestive heart failure, or this is a side effect of the patient being in congestive heart failure or a pulmonary embolus or those other things, COPD. All of those things that create higher pressure systems in the pulmonary network are going to make it a right-sided deviation. All right, let's look at this one. So I got lead 1, 2, and 3, AVR, AVL, and AVF. If I have lead 1, that is going negative. Lead 2 is going negative. Both thumbs down is an extreme right axis deviation. That tells me that this is not good, okay? This is a dead, 2 thumbs down. But if I use the hexaxial system, when I look at this, and this one's a little bit more tricky, but if you truly stop and think for a second, look in AVL. In AVL, you have about half amount going up and half amount going down. So when I look in AVL, I would call that the equiphasic lead. That points back to lead 2 based on our star of life. So when I get to lead 2, that is a negative deflection. And a negative deflection in lead 2 gives me a negative 120. So when I find a negative deflection in lead 2 on my chart, it's in the 11 o'clock position for you guys. It's a down arrow, right? Negative, and lead 2 is a negative 120. And that is an extreme right axis deviation. These are never good. Extreme right axis deviations, these patients are very, very sick and they need to be managed pretty quickly. All right, so let's look at this one. I got 1 AVL, or 1, 2, and 3, AVR, AVL, and AVF. So if I'm using the thumbs, I'm upright in lead 1 and I'm down in lead 2. So my thumbs are leaving each other. So this is going to end up being a left axis, okay? So what we need to do now is kind of look to see where are, using the hexaxial system, which one is equiphasic. And this one too is a little bit difficult. Let's look at 1. No. 2, I don't really think so. 3, no. And if you're like me, you're kind of trained to not really even pay attention to AVR. But in this finding here, AVR is our equiphasic lead. So if I have my equiphasic lead, and remember how that star of life points, AVR is going to point down to lead 3, okay? And as I look in lead 3, it is negative. So if I am negative in lead 3, that is going to end up giving me a negative 60. And if I put that on the chart, I just need to find that negative in lead 3. And it's going to be at about the 2 o'clock position on this. So I find my down arrow in lead 3. That gives me a negative 60. So I told you guys that it was left based on the thumbs, but this is actually a pathologic left. So there's something going on with your patient here, pathologic left. So they're outside of the normal range. Negative 60, left upper quadrant. It is a pathologic left. So this is what we started off with. Let's look at this one, and this is the final one, and then I'll give you guys time to ask questions. So I'm looking at 1, 2, and 3, AVR, AVL, and AVF. So in lead 1, what do you guys think? I think that I am going down if I'm using my thumbs method. Lead 2 really looks to me to be the equiphasic lead. So remember our rule. I have to go to lead 3 or AVF, correct? And when I do that, those are up. So I've got one coming down and one going up. They're heading right towards each other. So this is a right axis deviation. If I use the hexaxial system, I'm looking at lead 2. Lead 2 tells me that based on our star of life, AVL is actually where I'm looking, should be going, and that is a negative deflection. So when I find that negative deflection in AVL, if I kind of go back to my chart here, let's find AVL and find a negative deflection in AVL. And what does that end up telling you? This tells me, here's my negative, my blue arrow in AVL. That tells me that this patient is having a right axis deviation. So when you look at this at first, you guys are going, oh, okay, yeah, he's got some flipped T waves, maybe a little hypoxia. We'll give him some aspirin, we'll give him some oxygen and transport this patient to the hospital. But if you're truly looking at axis deviation, and I think we should be, it's telling you that there is something going on in that right ventricle. And maybe that is the reason why this patient isn't oxygenating and ventilating appropriately, is because they have pulmonary hypertension, or maybe they are suffering from a pulmonary embolus. And just by simply using your thumbs to think at lead 1 or 2, or using the hexaxial system if you choose to do that, it's going to end up giving you a lot more information about what might be going on for your patient. And then clearly, and to kind of summarize here, basically what we always need to think about is asking for that clinical finding and what the signs and symptoms are. So, how long has this been going on? And if this is, a 55-year-old male that is a truck driver and pulls over in your jurisdiction and starts having severe difficulty breathing all of a sudden, and you see flipped T waves in V1 through V5 basically, and you can figure out that this patient has a right axis deviation, truck driver, sudden onset, I'm thinking that this guy might be having a pulmonary embolus. Can we do anything for that in a pre-hospital setting? Not really, but we should at least notify that, hey, this guy's got a right axis deviation and I think it might be a pulmonary embolus.